afternoon, everybody. This is Dr. K from the Black Hills Regional Eye Institute, and today I wanted to show a case, a small pupil case. Now, there are a lot of reasons why a patient's eye might not dilate. They might have a condition called pseudoexfoliation, which tends to have poor dilation. They may be taking oral medications that reduce the tone of the iris that cause poor dilation. But whatever the reason, having a smaller pupil during cataract surgery makes the surgery more difficult, because the lens itself sits right behind the iris, and so if the pupil doesn't dilate, there's not a lot of access to the lens. That makes the surgery more difficult. It makes the lens and the cataract more difficult to remove. You also run the risk, if the pupil is small, of aspirating the iris or the pupil into the phaco probe when you're trying to remove the cataract, and that would then damage the iris. One option is what we're doing here. We're injecting some lidocaine phenylephrine solution to try and dilate the pupil. Use some strong medication inside the eye to try and get the pupil fully dilated. Another option would be to use an iris retraction device like a Malugin ring or iris hooks. There are Cambrava rings, another option that I'm not sure is available yet in the United States. Here I've chosen to use viscodilation, which is basically using the viscoelastic to further dilate the pupil. You can see this is kind of a floppy iris because it just kind of moves whenever you get near it, and most irises have a little more tonicity than that. The reason I've chosen to use just the viscoelastic to hold back or retract the iris and not use any iris retraction devices or tools is really because I don't want to damage the iris sphincter. The tools, the retraction devices, they hold back the iris, which can be helpful in certain situations, but in a light blue eye like this, where you can see that the pigment may be very loose, the retraction devices themselves may cause more damage than actually doing a safe and cautious surgery. And the goal, again, is to cause zero damage and get the cataract out of there safely. And so sometimes even the retraction devices, even though they are designed to safely remove the cataract with minimal damage to the iris, even sometimes they will cause more damage than I'm willing to tolerate. So here we are just going to attempt to remove the cataract through the small pupil, and with minimal contact with the iris and minimal liberation of iris pigment. And you'll see towards the end of the case, the second instrument brushes up against the iris, and there is some liberation of pigment, even though it's just incidental contact. And that is indication to me that not using any iris retraction devices was probably the right idea. So what we've done is we've just done some gentle hydrodissection and hydrodelineation. You can tell that the pupil is coming down because the viscoelastic that was in the eye that was used to dilate the pupil has come out. And what we're going to do is just try and stay as much as possible in the center of the eye, away from the iris tissue, and maybe a little bit deeper in the eye than the iris plane, in an attempt to only remove the cataract pieces and to not have any aspiration of iris tissue into either the IA probe or the phaco probe. We have just cleared the tip using quadrant removal. Now we're doing some gentle sculpting because I'm going to do a kind of a stop and chop technique here. We sculpt as deeply as possible, and then we put in our second instrument and put that deep inside the crater and separate. And so there we've got good separation. Now, I didn't use a lot of ultrasound energy or a lot of vacuum. I have the foot pedal at 0 right now because I don't want a lot of manipulation to the iris. I don't want a lot of pressure on the iris either from the irrigation or from the aspiration probe. So we use our second instrument to gently remove or coax out of the bag the pieces of cataract. And you can see we're kind of deep here in the bag. We want to stay away from that iris as much as possible. And I will also keep the second instrument in front of and slightly below the main phaco handpiece in an attempt to block any iris tissue from being aspirated. So I'll rotate the lens and we'll chop this next piece here in two, and that will we've got half the cataract out, so now we're going to have almost the entire section removed. And notice again, we're staying very deep in the capsular bag, and we will both liberate this piece and kind of remove it fairly deeply within the capsular bag in an attempt again, to not have the iris be aspirated. And the iris is behaving very nicely. We've got a good amount of viscoelastic in there, doing, again, some visco retraction. We'll get the last piece of cataract tissue out, and then we'll go for our epinucleus. Again, staying central in the eye. The further you get into the periphery with the phaco handpiece, the more likely you are to aspirate either tissue or components that you don't want to come up to the phaco probe. And you can see now that a majority of the cataract has been removed. There's still some epinucleus sitting centrally, and I don't really want to go try and get that with the phaco handpiece when I know that I can easily get it with the irrigation aspiration handpiece. And that irrigation aspiration handpiece has a much smaller opening, and so that smaller opening will minimize any aspiration of unwanted tissue like that, just right there. See that, how easily that came in? And now we're just going to go and try and get the cortical material. So a little bit of contact with the iris there, but it doesn't appear to have caused any issue. I think that the iris retraction devices that we could have used would have been a little more damaging than that incidental touch right there. Looks like that section of the iris tends to be more prone towards being aspirated, so we'll just try and go deep and avoid aspirating the iris tissue. I do sometimes aspirate from the center of the capsular bag in the periphery there, or in the posteriorly there, because I feel like I can get a majority of the cortex that way if there's few strands remaining, and then I'll power wash the capsule with the IA to remove any remaining cortical strands. There's just a little piece of cortex or epinucleus floating around, and there's another one probably sitting right by that opening for the second instrument. Just there you can see I contacted the iris with that probe, and you can see a little bit of pigment liberation there, and that's what we don't want. Again, it's some incidental contact. It wasn't very much, and that's exactly what I'm trying to avoid with any iris retraction devices. So we'll put our second instrument in and put our lens in, inject the lens, and get it positioned properly. We are going to use the Sinskey in this case to make sure that it's completely under the capsular axis 360 degrees, because it would be easy in a small pupil case to inadvertently inject the lens into the sulcus, and a one-piece lens like this obviously can't be in the sulcus, and so I'll use that second instrument to check and make sure that the lens is actually in the capsular bag. Now we'll go beneath the lens and we will remove the remaining viscoelastic material there. You can see where we've lost some small amount of iris pigment at about 7 or 8 o'clock there. There's a little bit of red reflex showing through. We are going to remove all of the viscoelastic in the angle and make sure our lens is centered, and then we'll complete the case by hydrating our incisions and injecting some medication into the eye to minimize infection and inflammation. So in this case, this wasn't, as the smallest pupil ever. We've definitely done smaller pupil cases, but it was a good example of how in certain situations you may want to avoid the use of an iris retraction device to prevent making the pupillary margin irregular and liberating more iris pigment than is necessary, because there's a lot of manipulation that goes on when you're inserting either iris hooks or a Malugin ring. But this case turned out very nicely. The patient did excellently with no ill effects from the small amount of pigment liberation at about 8 o'clock there. I appreciate everybody watching. I hope you folks are doing great, and thank you for watching my YouTube channel. You have a great day.